So the purpose of this case study is to discuss a rare condition in a pediatric patient, examine the current literature that supports evidence-based practice, and evaluate the intervention that I used. So a little bit about my patient. She's a 15-year-old right-handed female. She had a right shoulder injury during birth, which was a forceful removal. And so whenever she brings her hand towards her face, she abducts her arm like this, and she's unable to straighten her arm all the way. And so these all result in having difficulty eating, putting up her hair, performing push-ups, and running during her soccer games. Her father reported no significant surgical history. She had eye correction and tonsils removed at least 3 years prior to this, and she had no previous treatment for this condition. And so she stated to me that she had been having difficulty with this for many years and just got progressively or slowly got more difficult to perform these activities over the last year or so. And so I don't know why this slide looks like this. But so during my objective findings, I found that she had a decreased thoracic and lumbar curves. She had the normal rounded shoulders forward head position. And so she had increased scapular union, and this consists more on the right than the left. She denied any numbness, tingling, or sensory changes into either one of her extremities. And she had very minimal pain, and this pain only occurred at her elbow, more on the lateral side. And this was during excessive use of her right arm or at extreme end ranges. And so her range of motion, she was within normal limits at her shoulder on both sides, except for her right external rotation. So she was able to achieve 15 degrees actively and actually at about 20 degrees passively. She had a full elbow flexion on both sides and was lacking about 10 degrees actively and about 8 degrees passively on that right. Wrist motion was within normal limits on both sides. So this says that she had approximately 95 degrees of that abduction whenever she brought her hand towards her face. And so she also, whenever she performed the external rotation, she had trunk extension, kind of rotation, side bending motions to compensate, as well as wrist extension to compensate for that extra rotation. And so for strength testing, she was kind of symmetrical both sides. The only limitation she really had more so was at her external rotation. She was able to achieve a little over half of her available range of motion for external rotation, so I gave her a 3- out of 5. Her traps were all more weak on the right than the left, as you can see. So she was unable to perform the full prone fly position through the full range of motion, and so therefore I gave her the 3- for that, as well as with the lower trap testing as well. The only pain she experienced was on her right elbow and wrist motions when I tested her strength. Her joint mobility was pretty normal. It was just ever so slightly limited on the right for both shoulder and elbow. And she was also hypomobile in her mid-thoracic spine. And then the significant palpation findings I had were her right bicep and subscap were pretty adhesed. I felt like those were limiting more to her range of motion, indicating those like muscular end feels that I felt when I tested her range of motion. And there were no other findings or anything that indicated for me to do any shoulder or special tests, such as knee or open can, biceps open, anything like that. I did not feel that was necessary to do, nor did I fully check any tension testing. I didn't think that was necessary at the time. So based on my findings, my first kind of initial thought was a brachial plexus injury due to the traction on her arm. In the research I found more for Erb's palsy, saying that one of the common consequences is an internal rotation contracture, as well as lack of elbow extension. However, her and her father were unable to really give me a lot of details on the birth complication. So the mom knew more, however, she was never present for any of the treatments. And so we weren't really sure exactly what happened at the birth. And so that's why I fully didn't rule in a brachial plexus injury. So for reduced external rotation, a lot of articles I found stated that if you lack external rotation, whenever you bring your hand towards your face, you result in that abduction compensation. So she experienced that, so that was kind of one of my other thoughts there. as well as the shortened muscles and scapular function. Shoulder blades play a big role in any overhead motion and just shoulder motion in general, as well as weak and then any joint limitations that she may have had. So I decided that her primary impairment was her reduced external rotation, and I felt it was more due to her subscap tissue restriction, since that was pretty significant, as well as then that also then results in her abduction compensation. And a lot of the research I found says just that if you have a lack of external rotation or if you have fatigue in those muscles, the shoulder blades can kind of kick in a little bit as well. You can get more dyskinesis with that, as well as the compensations that I've already talked about. It's the same thing too. I felt her elbow extension was more limited to her bicep restrictions, and then she just exhibited those compensations of her trunk and her wrist. So all of these led to her limitations of more specifically eating and putting up her hair, as well as her running during soccer. So those were her biggest goals. So she wanted to increase her strength and range of motion. So initially I set a plan of care for 2 times a week for 8 weeks. And the goals I had set for her were to her to be independent with her home exercise program, for her to increase her trap strength, more on that right side, and then to also increase her arm swing during ambulation. And then long-term goals, I had her to have less than 60 degrees abduction whenever she did perform eating, and then to have proper arm swing with soccer. She had really good prognosis due to her young age, and she was really motivated to improve her condition, though she had really good family support throughout it. And one of the big negative factors I felt was the chronicity of her symptoms. Currently, any questions? Yes.
All of her range of motion measured standing or supine?
Seated was most of it. We just kind of like did a general screen. And so single plane was good. It was kind of more whenever she did multi-plane movements, was the only time she had that.
You mentioned she had difficulty with arm swing during running.
Mm-hmm.
Can you describe it?
We didn't actually fully initially look at her arm swing, but she had said that she sometimes tends to almost hit people when she's running, and I was like, are you sure you don't want to just elbow people? So she said it kind of would just swing out, and so I kind of just a little bit more, but she said it slowly improved as we went through. Yes.
Did you collect any outcome measures?
I did not. That I actually listed as one of my limitations, that we did not perform an outcome measure with her. Any other questions? So the first week I saw her was the initial eval, and so I collected my objective findings. And then I performed soft tissue mobilization to both her right bicep and her subscap. And then I gave her 20 reps of scapular retractions as well as an external rotation stretch at the door. I did more 20 reps, more for the endurance to those scapular muscles, because she has to maintain that posture with any activity that she's going to do. So I wanted a little bit more endurance for that. We're going to work on it at home. The second week I saw her, I added a manual external rotation and elbow stretch to really work on those limitations that she had, as well as performing the soft tissue to her bicep. And so whenever she came in, we started with a 5-minute warm-up on the bike just to get her muscles warmed up before I worked on her. And then I modified her external rotation stretch because she told me she had pain when she did that at the door. And so I modified it to be performed in supine with a stick to limit those back compensations that she experienced and to have better scapular positioning with that. And she was able to do that without pain. So I then gave that to her for home. The scapular PNF patterns that I did, I worked kind of all planes and really focused more on emphasis of the depression of the scapula to really work on that positioning. And research I found saying that if a patient is more aware of kind of their shoulder blade and where it is in relation to what they're doing, helps with better activation of their shoulder muscle or scapular muscles and better posture overall. The baby cobra exercise, which is what we call this in the clinic. So the patient is prone and they retract their shoulder blades and then do a slight chest elevation. And so we perform this exercise since she was unable to do the full prone fly position. So this helped to shorten that lever arm for her to be able to do this. And so she required cues, both verbal and tactile, to eliminate kind of more the upper trap compensation and to get really good muscle activation. And then we performed the serratus punch to help work on the scapular winging and activation of that serratus anterior. Week 3, she started seeing more improvements in her elbow extension, very little in her external rotation, as she started improving a little bit with that. And so then exercises, she still requires cues for positioning of her shoulder blades more in prone. She was able to achieve it pretty well in sitting. And so then I progressed some of her exercises to sideline external rotation, so she could get some of the muscle activation against gravity. In research I found saying this is one of the best positions to activate those external rotators, and especially compared to standing. And so I added a tricep pull down to try to get those triceps to work to help with that elbow extension. I did a lat pull more for the adduction portion of it too, when her arm is out to the sides for her to work on training it to come back to her side better. And a lot of all of our exercises that we did, we based all of our dosage on her form and pain levels. And fatigue was a big issue that we had. And so she was able to do lower reps of things. So we had to take repeated breaks in order for her to kind of rest. And then we could do a few more repetitions of the exercises in order to have the good proper form that we wanted. So week 4, we were able to achieve more elbow extension. She was lacking about 5 degrees passively. And so exercises, I wanted just to work on more of that scapular strengthening endurance. And so we added rows and then flexion with the Thayer band. So you have the Thayer band wrapped around your wrist and you keep tension on the band the whole time and then perform shoulder flexion. In the article I found for this exercise says that it really helps to activate the external rotators and improve the middle and lower trap to kind of counterbalance the upper trap motion and activation with that. So same thing for scapular positioning was beginning to improve. Sitting, it was pretty good in sitting, and so she was slowly able to start adding a longer lever arm to her prone scapular retractions in that position. Week 5, we were able to achieve full elbow extension, so she was pretty excited about that. Her bicep tissue pliability improved a lot. It's still limiting a little bit more, especially actively, and then her external rotation was still slowly improving. That was still her biggest limitation that we were seeing. And so we added horizontal abduction just to continue to improve the scapular muscle activation and coordination with everything. And so if you do an external rotation, that helps to activate a little bit of the serratus anterior as well as just the normal shoulder blade muscles and some of the external rotators. And so same thing, like I said, still adding a little bit more lever arm as tolerated as fatigue levels were able to. Week 6 was the last week I saw her. And so we still had slight limitations in the elbow active range of motion, but it was still getting better. And then this week she had more wrist extension compensations than she did previously. She still had those back compensations. However, she was slowly starting to improve those a little bit more. So I added wrist flexion to kind of counterbalance that compensation in her wrist. And so she just had that one a little bit more there. And so the last day I saw her, she was actually due for a progress note, so it worked out pretty well. Her pain, same thing as before, very minimal, still only at those extreme end ranges. And with just the excessive use of her arm, she says like more near the end of the day after she used it. Her active range of motion for her shoulder external rotation improved to about 25 degrees. We're going to get her a little bit more passively to 30. And so like I said, we were able to achieve that full passive range of motion for elbow extension, and she was lacking about 7 degrees actively. Her abduction compensation also improved, reducing down to about 85 degrees And so she said she could see the difference and feel the difference a little bit more, that she wasn't bringing her elbow up as much. And so she still exhibited those same trunk compensations with external rotation. However, she said she was more aware of them and could slowly start to correct them a little bit more herself. And so I feel like some of the reasons, so external rotation here for strength, upper extremity, both sides improved. Her wrist flexion was still, didn't really improve that much since we didn't focus on it too much until that kind of last week that I was with her. Her trap manual muscle tests were about the same. However, just the quality of motion overall, she was able to activate the muscles a little bit better, be just more aware of her shoulder blade positioning. And so a little bit more difficulty still in prone, but in seated position, she didn't have any problems with that. And so I felt the criticism of her symptoms could be lacking of why we didn't see as much improvement in the external rotation as we did with the elbow extension. And so the palpation still slowly started to improve, but still pretty limited in her subscap. So for her goals, she met her independence with home exercise program, and we would continually add more exercises for her to do at home. So that worked really well, and so she's very consistent and compliant with those. Her manual muscle tests for her traps were improving. So we weren't able to meet any of those by the time I finished with her, but she was just better overall quality, like I had said. She had increased arm swings during ambulation, but still had difficulty with it during a full soccer game. And that was just from patients self-reporting that to us. And then same thing with the eating technique. Like I said, it was about at 85 degrees. So she still hadn't fully met that goal yet. And so she would continue to be seen for about 6-ish more weeks after I left. And so I was able to obtain the information from my CI of what they continued with her. They added core exercises due to an onset of back pain. I'm not really sure what caused the back pain. And so she added those ones and we continued with the other exercises we had already been doing. So she was able to achieve 60 degrees of external rotation. I'm not sure if that's active or passive, but she's able to get 60 degrees there. And then lacking about 5 degrees elbow extension actively. Her abduction compensation continued to decrease to about 75 degrees. And so overall, she just had improved quality of motion, strength, endurance of her muscles, and just that activation. And just became really more aware of her compensations. And she said she was able to correct them a little bit more throughout the day. So some of my limitations, like I said, was the outcome measure. In the clinic, we didn't do too many, but I felt like that I could have still implemented one, and it would have helped just to get a better understanding of what other activities were going on with her, as well as updating objective findings we only did on progress notes. And so I felt like that was also hard to really see where her improvements were, like what she was still having difficulty with, and really where to focus on the next couple treatments. So I would have definitely liked to update those findings a lot more than we did. Like I said, I was unable to follow her all the way through discharge. And so I would have loved to do so much more with her. And due to her fatigue levels, we had 45 minutes per patient, like individually with each patient. And so she was able to do about 35 minutes due to her just fatigue levels. Near the end, she was able to get a little bit more. And so that was just a limitation that we weren't able to do a full session with her. And so what would I have done differently? After the fact, I had found a couple articles saying that soft tissue on the subscap in conjunction with PNF diagnosis, specifically the D2, really helped with external rotation. So I would have liked to have gotten that article earlier to really try that. I didn't do as much soft tissue on the subscap as I probably would have liked, since it was a really awkward positioning and she was also kind of ticklish. So it didn't work too well for her. I did intermittent joint modes on her elbow, but I never actually did any on her shoulder, just to see if that would have worked, and then kind of do the retest before and after, and really see what was the best treatment that worked for her to get the most extra rotation that we could. And then a full neuro and cervical kind of assessment to completely rule out any things in the lower cervical spine, especially the nerves, like upper limb tension tests. This is performed to completely rule out the nerves due to the chronicity of that condition. And then just other exercises to work on muscles, just in different positioning, just adduction with their bands and the different serious anterior exercises, such as wall slides or dynamic hugs. I found that those are really good to help activate that serratus anterior muscle. And then just the outcomes and objectives, like I had said. Yes.
No one else is I think you had a really good reflection list on some things that I'm looking back, looking at what
It's a good learning experience.
yeah, that's one of the main purposes of it, so good for you. I really, this is more of a confident question. I think the probably was right about the joint mobilization because you're 15 years, you've not moved your shoulder in external rotation, abduction like that. The likelihood of having capsular restrictions, right, very high. We usually think of that, acutely, is it muscle, is it capsule? But if there's been a limitation for a long time, you can pretty much guarantee that you can have restrictions in all those issues. So kind of a good thing to keep in mind. What about T-spine manipulation? Is that any consideration at all?
We didn't. At this point, we didn't do a lot of manipulations, and so it wasn't really kind of the forefront of my mind at the time. I think we did a couple mopes on our T-spine, but it wasn't really a big focus. I'm not really sure why, but we kind of did it a few times. So it's definitely something to continue to reassess and see if that changes anything as well. So.
Test, treat, retest. That way you wouldn't go 3 weeks with a 5-year change.
Yeah, exactly. So yeah, that's definitely something I would have liked to change. So, yes.
Did you do any closed chain activities for her?
Not that I can remember, but that's definitely like a good thing to consider and just see.
I wasn't sure
if it
she could
works and
tolerate
stuff.
that.
So, yeah.
Just for shoulder stability and functional sorts of things.
Definitely something to consider.